Hello, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at COH Core. Welcome to our webinar titled The Role of Interoperability in Value-Based Payment with guest speaker Dr. Kate Goodrich, Director of the CMS Center for Clinical Standards and Quality. I'd like to mention a few logistical items. You'll be able to download a copy of today's presentation from the cahoh.org website tomorrow. Also, a copy of the slides and the recording will be emailed to you in the next day or so. We will save time at the end of today's program to respond to your questions. I encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. This webinar is part of our series on the topic of value-based payments. I'd like to thank our featured speaker for joining us today, Dr. Kate Goodrich. She will be providing an overview of CMS activities related to interoperability and VBP. Today, we start off with a brief introduction on VBP and COH Core activities to support its operational components of VBP. Then we will move on to our featured presentation, which is Value-Based Purchasing and Interoperability at CMS. So let's get started with our first presenter, COH Core Director, Erin Weber.
Thanks, Jessica, and thanks so much, everyone, for joining us today. I'm going to start off the presentation with a brief overview of value-based payments and what's going on in the industry in terms of adoption, talk a little bit about some of the work we're doing here at COH Core, and then leave the bulk of the time for Dr. Goodrich to share some of CMS's important work in this area. We all know that value-based care and value-based payment are really popular topics in healthcare right now. The aim is to lower the cost of care, improve the quality of care with the goal of healthier people, while also, which is now part of what the quadruple aim is, in thinking about improving the life of the healthcare providers as well. So not overburdening them from an administrative perspective in particular. There are many types and many different models of value-based payments being used in the industry right now. Everything from pay for performance to bundled payments to full risk models. So I know Dr. Goodrich is going to talk about some of those in relationship to CMS in a minute. The next slide demonstrates where the industry is right now in terms of adoption of these models. In just the last 2 to 3 years, we've seen increase in the number of commercial payers using value-based mechanisms from 12% to almost a quarter. And then you can see across the different types of payment, all types of payers are incorporating some type of value-based payment into their models. In particular, we're seeing about 25% across the board between commercial and government payers using these models. Whenever you see a shift in how an industry is addressing a challenge or trying to solve problems, there's always readiness gaps that the industry experiences. And a recent survey looked at where in particular the industry is challenged in adopting value-based payment programs. And you can see on the chart here, this demonstrates where organizations that said something would be really important, but yet they did not have the capability to do so. So about 30 to 33% of respondents to this survey said external and internal interoperability were really critical to successful value-based programs. However, they also rated themselves as not yet capable in this area. So you can see not only interoperability, but assessing ROI and real-time data access are all more operational and administrative components of value-based payment that will be really critical to creating a foundation for these models to move forward. As Jessica mentioned, today's focus is on data sharing and interoperability, but that means much more than just the technical specs to exchange data between two organizations. Our research really looked at 4 different types of interoperability challenges. Process interoperability, having common expectations for how operational processes and workloads support data exchange. Are systems available? How soon should I expect a response? Did my data, did the receiver actually get the data I was sending? Technical interoperability, again, that is the probably what we all think of traditionally as interoperability. How are we sending data between each other? Semantic interoperability came up as a major challenge as well. What does the data mean? Do we have a standard vocabulary so that we can communicate with different stakeholders on these topics? And policy interoperability to ensure that we are collaborating in appropriate way between different stakeholders. So that's a bit of a landscape of where the industry is, specifically within CAQH Core. For those of you that are less familiar, CAQH Core was founded back in 2005 to address some of the challenges the industry was having in adopting electronic transactions for the fee-for-service healthcare environment. Specifically, the original HIPAA legislation had put forth standards for the exchange of billing and payment information. However, the experience of the industry was that the different stakeholders were using the transactions differently. So a provider working with multiple health plans was getting different information in different ways using the standard transactions. So the industry came together and developed operating rules to support these administrative transactions to improve the efficiency and the automation of this data exchange between plans and providers. The core board, which represents plans, payers, and vendors, saw some of these same challenges occurring with the implementation of value-based care in the industry. And so CORE expanded its scope a couple years ago to focusing on these administrative challenges and the adoption of both fee-for-service and value-based payments. And as a result of that, we conducted a 2-year study looking at the operational challenges the industry was having as they transitioned to value-based payments. The new report that we put out at the end of March outlines some of these opportunity areas and particularly identifies areas where if the industry were to come together and collaborate in the similar way that they did with the operating rules, they could create more uniformity without compromising the competitive value of the value-based models that would enable more smooth adoption of value-based payments. The report outlines 5 opportunity areas and recommendations that should be addressed by the industry, whether by CORE or others. The report actually calls out some candidate organizations and stakeholder types to lead on these topic areas to help propel operations forward so that proprietary approaches don't become entrenched as these value-based payment models evolve. Very specifically on the next slide, the vision of this work is to develop a common foundation that drives adoption of evolving value-based payment models by reducing administrative burdens, improving information exchange, and enhancing transparency. And the 5 areas of focus that came out of the research are highlighted on this slide: data quality and standardization, interoperability, patient risk stratification, provider attribution, and quality measurement. For those that are interested in the deeper dive, we have some prior webinar recordings on the research in particular available on our website. I'm not going to go into the details today except to talk a little bit about the interoperability opportunity area to give time for our guest speaker. With regard to interoperability, the report specifically called out both technical and process interoperability as the 2 major areas of focus. Data retrieval and integration roadblocks, research participants noted were really causing delays in quality of care analytics and causing delays in actionable data reaching the point of care and having an impact. The report identifies 2 strategies for addressing this challenge with some more detailed recommendations below. The first is to promote technical interoperability by encouraging the use of existing and emerging standards, and the other is to promote process interoperability by cataloging some of the best practices that are coming out as these payment models are emerging. Even since we started the research on this topic, we have seen momentum happening within individual organizations and at a national level. And I'm going to talk in a minute, on the next slide, talk about some of the federal efforts related to interoperability that are impacting value-based payment. I'm not going to talk about the CMS efforts. I will leave that to Dr. Goodrich. But in particular, I want to highlight the 21st Century Cures Act, which encourages interoperability of electronic health records and patient access to their health data. It discourages information blocking and is focused on reducing the physician documentation burden and creating a usable reporting system across the industry. ONC, the Office of the National Coordinator for Health Information Technology, has put forth a interoperability roadmap with a 10-year plan for advancing connectivity and interoperability of health IT, and most recently put forth a draft trusted exchange framework to help improve the exchange of data among health information networks. So with that, I'm going to pause. I think I'm going to turn it over to Jessica to do a polling question, and then Dr. Goodrich can share more about the work that CMS is doing and how it relates to the ONC work.
Thank you so much, Erin, for giving us that overview. And with that, we can start with our first polling question. As you heard Erin mention, the 5 opportunity areas that our data showed were critical. We want to hear from you. Which one of these 5 is the biggest pain point for your organization? So if we could launch the poll. Oh, it's already launched. So please feel free to give us your feedback. This is information that is very helpful for us as we try to tailor our work and also our future education sessions on these topics. In addition, as we're paused, I want to remind you that if you have any questions, please submit them now. We look forward to that portion of the webinar later today. So let's give this a few more seconds and we can share the results. Okay, let's go ahead and share the results with the audience. You know, it is really interesting that we see these trends. You know, there's those first 2 are clearly top of mind and pain points for our audience, but there are still a few others that are important. I encourage you to go to our website and look at our report, which has more information on the recommendations and some strategies. And we'll also be covering these topics in future webinars. And with that, I'd like to welcome our featured speaker, Dr. Kate Goodrich. She's the director of the CMS Center for Clinical Standards and Quality. Previously, Dr. Goodrich served as the director of the Quality Measurement and Health Assessment Group at CCSQ and was also a senior advisor to the director of CCSQ, as well as the chief medical officer. Before that, she served as the medical officer and the assistant secretary for planning and evaluation at HHS, where she managed a portfolio of work on comparative effectiveness research and quality measurement and improvement. Whew. Welcome, Dr. Goodrich. We're really happy to have you here today.
Thank you, Jessica. Thank you, everybody, for joining today. I'm excited to talk to you about the work that we are doing at CMS as it relates to expanding on value-based payments over time. My talk will be fairly high level, but hopefully will give you a flavor of what we're doing and sort of the direction we're taking and how interoperability really is a critical component of the success of the expansion of value-based purchasing. So if we can go to the next slide. Oh, well, you can read this one at your leisure. You can go to the next slide. Okay, so this really just shows the key characteristics of where our payment system And this is not unique to Medicare. This is across, all payers, where our health system really has been in previous years and what it is evolving to. Very, very important. I would just re-emphasize this is not just about CMS. This is not just about Medicare and Medicaid. There are numerous commercial payers who are also moving in this direction, and I anticipate we'll be seeing accelerated growth in this direction across all payers over the coming years. So previously, our health system was really very focused on volume, right? So paying for things, paying for more visits, more tests, et cetera. This, of course, has led to significantly increased costs in our healthcare system, and we don't necessarily have the best quality results to show for it. So this is really unsustainable, and our system has been traditionally characterized by very fragmented care, something that probably many of us have experienced ourselves or our loved ones have. And so this is very representative of the attributes of the current fee-for-service payment system. Where we're going, and where we're already seeing significant progress, is in a future state that is much more centered around the patient's needs, where what we're paying for is better health outcomes at lower costs, which we believe will be much more sustainable, and will actually directly incentivize coordinated care. And there's a number of ways to do this. There's a number of ways that you can structure value-based purchasing, whether it be through population-level models like accountable care organizations or episode-based payments. And I'll talk a little bit about a recent model that we announced that's based on episodes. Medical homes also are a popular model of care. And overall, key and foundational to all of this is transparency in quality and cost. So next slide. So at CMS, we have really defined the key high-level focus areas that we and other payers need to focus on in order for all of this to become a reality. Number one, we have to focus on how we pay providers. Again, not paying less for number of items and services and more for the quality of care that's provided as reflected as patient outcomes, patient experience, and cost. Number two, we need to directly incentivize better ways of delivering care, so more direct incentives for care coordination, chronic care management, shared decision-making with patients, and those types of things. And very, very important, and what we're going to talk about today has to do with having access to information. And this really means a few things. This means not only transparency of performance on quality and cost, so that patients can make better choices. It's also a significant lever and incentive for providers to improve. But also providers, in order to be able to improve, must have the information about their patients and about their population of patients at their fingertips in order to be able to drive improvement. And that's really where interoperability comes in, because as the poll just noted and as the previous statistics noted, the lack of interoperability, which is really a reflection of the lack of having data at your fingertips that you need in order to provide the best high quality care, is definitely an impediment to moving into different payment arrangements. So we think having information and sharing of information across providers and with patients is a foundational principle for value-based care. Next slide. So first, I just want to tell you about CMS's strategic goals. These were announced last year by Administrator Verma, coming into the agency last March. So our goals are to empower patients and doctors to make decisions about their health care. That means they need data. That means that they need information. Usher in a new era of state flexibility and local leadership. So really focusing on the outcomes of care and allowing people at the local level to really innovate on how to provide that high quality care. So again, supporting innovative approaches to improve quality, accessibility, and affordability. Again, you need data to do that. And improving the CMS customer experience, whether that be the beneficiary or the patient, and them having the information they need in a way that they can use it and understand it, or whether it be the provider. Same thing, they need information as well. Next slide. So I just want to tell you a little bit about some of the work that's happening at CMS, some of the major programs around value-based care, and maybe tie that in a little bit to interoperability. So many of you, hopefully most of you, have heard about the Quality Payment Program. This was authorized under the MACRA legislation in 2015. We actually just completed the first year of MACRA. So clinicians are either part of MIPS, the Merit-Based Incentive Payment System, and we know that the majority of clinicians are participating in MIPS as opposed to APMs. And the other pathway is advanced APMs, and these are APMs that base payment on performance on quality measures, and that require the use of certified EHR technology, but that also take on what's called more than nominal risk, which really is downside risk. And so we have, we think about, I want to say 10 to 15% of clinicians in the first year of the program are part of advanced APMs. We anticipate that that is going to increase significantly going forward, including in 2018. So we're off to a good start. We just finished our first data submission period, but in both MIPS and APMs, providers are held accountable for performance on quality metrics, performance on cost, use of health information technology, and undertaking activities to improve care for their patients. Next slide. We identified a number of principles and strategic goals around the Quality Payment Program in year one. You see them listed here. I will only highlight a couple of them. Of course, improving patient outcomes is number one. We're very, very focused on finding ways continuously to reduce burden on clinicians. Part of that is by ensuring that they have information about the program, but also about their own performance and about their patients at their fingertips. So a number of our policies are really focused on that as well. Improved data and information sharing is a strategic goal for this program, and this gets directly to some of the policies that are related to interoperability and data exchange, again, with patients across providers, but also between providers and CMS as well. Next slide. Just briefly an overview of MIPS and APMs. The MIPS categories you see here, these are required by statute. So again, showing that we do hold providers accountable for all the things you see here: quality, cost, improvement. What you see here is called advancing care information. This is the old meaningful use. Surprise, we have a new name, which is promoting interoperability, to really show the focus of our requirements around use of health IT are really about interoperability. So we score clinicians on each of these categories, roll it up into a final score, and then payment gets adjusted up or down depending upon that final score. Next slide. Advanced APMs, again, I mentioned before, you have to base payment on quality and cost, or total cost of care. Have to use certified health IT, and there must be a nominal risk of standard. So what we finalized for the first year of the program was that the total potential risk must be at least 8% of Part A and B revenue, or 3% of the expected expenditures that an APM entity is responsible for. We maintained that standard through 2020. One important thing to note here is that clinicians who participate in an advanced APM and meet certain patient or revenue thresholds through that advanced APM then do not report to MIPS, and they get a 5% lump sum bonus. Next slide. So in 2017, one of the things that people have been very concerned about is that we don't have very many advanced APMs that are focused on clinicians, and that's true. We have 6 for 2017. You see them listed here. And we anticipate, again, adding more over time. We are working very hard to add new payment models as we develop them or as ideas are brought to us. I'll be telling you about one of them. I think it may be the next slide. So why don't we go on to the next slide? Right. So we announced recently something called BPCI Advanced. So this builds off of an alternative payment model that sort of had 4 tracks to it has come to completion or is coming to completion that's been around for a few years. So this really is around care coordination, focused on care coordination for patients between their hospitalization, then if they go into a post-acute care setting like a SNF, and then going home. The episode really is across that journey for the patient from hospital to post-acute care to home. And really, this is focused on engaging clinicians much more substantively than the previous model did. So let's go to the next slide. So what is an episode? So a bundled clinical episode, again, links quality and cost across all of these settings. And through this model, clinicians may earn additional incentives through this model. This is considered an advanced APM, so clinicians who are participating in this or who choose to participate in this, and by the way, this model would begin in 2019, but clinicians who choose to participate in this have potential incentives and rewards associated with it, but they would not have to report to MIPS. However, if they don't meet certain quality and cost targets, they may end up owing money back to CMS, which really is the way that most of our models work. That have downside financial risk. We have quality and cost targets, total cost of care targets for each provider, whether that be a hospital, a clinician, or a group practice. And if you exceed those targets, do better. So better quality, lower cost, you get to share in some of those savings. However, if you spend more or have really much lower quality than expected, you may owe money back. So that's at a very high level, typical way that these models work. Next slide. So the clinical episodes that are part of BPCI Advanced, and I want to say there's about 35 of these episodes that are centered around clinical conditions or procedures, can be led by either a hospital or by physician group practices. BPCI, the original one, was only led by hospitals and post-acute care settings. So now this allows clinicians to lead these episodes and therefore be part of an advanced APM for the purposes of the quality payment program. Next slide. So the way that it works generally, and I'm really just showing this for illustrative purposes to give you a sense of how our models often work in general. A clinical episode has to have a trigger. What begins the episode? And that trigger, in the case of this model, is either an inpatient hospital stay, such as an admission for an acute MI, acute myocardial infarction, as an example, or triggered by an outpatient procedure, which, for example, could be cardiac catheterization, for example. The episode can be attributed to the physician group practice or an acute care hospital. Care would be provided under standard fee-for-service payments. So for this model, clinicians or hospitals would still submit claims associated with that particular episode. And then at the end of each performance period, and our performance periods tend to be calendar years, we assess quality and cost at the end of that calendar year, and then we would go back and reconcile payments because the clinicians would already have gotten reimbursed through the claims that they submit. We would go back and reconcile payments and either give some money back or whatever the added incentives are, or we would require the providers to give money back to CMS, again, if they exceed cost and quality targets. Next slide. So that really was intended just to give you a general overview, again, very high level of how many of our value-based purchasing models work. I also want to put interoperability into the context of our overarching priority around reducing administrative burden on clinicians and on beneficiaries. So we have a major initiative going on called Patients Over Paperwork. And again, this is in order to not only reduce burden on clinicians, but to do that really in service of better quality of care for patients and ensuring high quality, safe care for patients with a better beneficiary experience. Next slide. So we have some specific goals around this initiative. We want to increase the number of customers that we directly interact with and engage with to inform us about their pain points and what's working well. We want to decrease the hours and dollars that clinicians and providers spend on CMS mandated compliance, and we want to increase the proportion of tasks that CMS customers, whether you're a clinician, a hospital, a home health agency, or a patient that they can do in a completely digital way. And again, the overlay for all of this is improved patient health outcomes as well. Next slide. So we have set up an overarching process within the agency to take a really detailed look at our regulations, but also what we require of our customers that isn't through regulation, but maybe through guidance or something else, as well as our own operations, to really think very specifically about ways in which we can reduce burden. So we've done a number of things. We have a CMS-wide sort of steering committee that I lead to do this work and to prioritize what we should be working on. We did formal requests for information. Some of you all may have responded to some of these to give us very specific ideas about ways in which we can reduce burden. We also have very customer-centered work groups. So we have a clinician work group, a beneficiary work group, and a SNF work group right now. We are just kicking off our hospital and hospice work groups. The idea here is for these work groups to basically go out and see, to go out into our various communities across the country, into these organizations, to be side by side with providers or beneficiaries and understand much more about their day-to-day work and the ways in which what CMS is requiring of them may be making their work harder, may unfortunately lead to less time spent with patients, and to give us ideas, I think to create some empathy, but also to give us ideas about specific ways in which we can reduce administrative burden. So we undertake a process that's called journey mapping, again, to really understand from beginning to end the provider or the beneficiary's experience in interacting with CMS in numerous ways. So we're working on this. We have a number of cross-agency initiatives that are really about reducing burden, but have other goals as well. So, for example, our meaningful measures work, which I'll just briefly talk about in a minute, promoting interoperability. Much of that is very centered around reducing burden, as well as, of course, ensuring patients and providers have access to the information they need. And, of course, a lot of stakeholder engagement work that's going on. Next slide. So just a few examples of things we've done. So we reduced the number of EHR or meaningful use measures in the quality payment program. We also recently published our IPPS rule, which is the inpatient prospective payment system rule. And we had some new proposals around meaningful use, again, what we now call promoting interoperability. I'll talk about in a minute. We developed an API, an application programming interface, an app, for data submission under the quality payment program that has been very, very well received, very successful. The feedback we've gotten is that it has made submitting data to CMS significantly easier than it's ever been. Now, we only used it for registries through the quality payment program, but we do plan to expand it to EMR vendors and anybody else who wants to use it, and then ultimately have something very similar available for our other programs as well. We developed a very user-friendly website for QPP, and while that may seem like sort of a very CMS-centric thing to put up here, the entire reason that we took a whole new approach in how we communicate with clinicians about this very complicated program was because what we had heard from clinicians about our legacy programs like Meaningful Use and PQRS was, your website is way too difficult to find things, and when we do find it, it is very, very hard to understand, and we spend hours trying to understand your programs. And that is hours taken away from clinical care or from something else that's really important. So we developed this new site, a new way of developing a website using human-centered design expressly for the purpose of reducing the amount of time it takes to absorb and understand information about what clinicians and their practice managers have to do. And then recently we also announced, this didn't have to go through regulation, fortunately, something that people I think have been really happy about, which is we no longer require that teaching physicians have to re-document history, physical, and everything else when a medical student they're working with has done that documentation. So we believe, and we're already seeing, will I think lead to much greater satisfaction on the part of attending physicians, but also medical students who unfortunately have not been getting the experience they need in writing notes because of our rules that said that the teaching physician had to redocument everything. So this has been people have been very pleased with this one. And there's been a lot of other work that's happened. These are just a few examples. Next slide. A little bit about meaningful measures. This, you all can certainly have a copy of these slides so you can read this in more detail at your leisure. But the idea here is really to take a hard look at not only our current measure portfolio, but in general, what are the things that we really should be measuring where there's still the biggest quality gaps or quality issues, and really hone in on those things, and not get sort of distracted by other measures that are just where there's already very high performance, or the measures themselves are very problematic. So we've been approaching this in a few ways to really figure out how we can hone in on the measures that are just truly the most meaningful for patients, their families, and for clinicians. So we've taken an approach to do that built off of a lot of work that's happened by the National Quality Forum, the National Academy of Medicine, the Healthcare Payment Learning and Action Network, and lots of other stakeholders out there have been doing a lot of work to identify the most important areas for measurement. So next slide. So we've sort of taken a three-pronged approach here. Number one, we're going to remove low-value measures. Again, this regulation, the proposed rule we just put out, proposes to remove a number of measures from our hospital programs that are topped out or are otherwise problematic or duplicative. We also, though, know we have a lot of areas that we need to be measuring because there's significant quality problems. We don't have measures. So that's how we need to really focus our measure development efforts, is to fill in a number of these gaps and focus on outcome and patient-reported outcome measures. But I think very importantly is the third bullet, which is that we and others need to work very intensively with health IT organizations, registries, and clinicians to reduce the actual work that's required to capture data for quality measurement and to report quality measures. So it's not enough, I think, just to be sure you've got the right measures in place. That's critical. But even when you have the right measures in place, we need to make it easier for people to actually collect the data on those measures and report it. There's some great examples out there of really innovative work that's being done to significantly reduce burden. So we are actively learning from that so we can figure out how we can spread that so that the burden is reduced for everyone. And again, clinicians can really spend more time with patients and less time trying to implement workflows that don't really work very well just for the purpose of quality measurement. Next slide. So a little bit about My Healthy Data, another big initiative here at CMS, which is really, again, about interoperability. This is about getting data into the hands of patients and across providers. Next slide. So we're approaching this in a few different ways. Number one, you may have heard our announcement around Blue Button 2.0. I'll tell you a little bit about that, where we are working with over, I think, 100 innovators to develop APIs that can basically take Medicare claims data and be able to display it and provide information to patients and others on these claims data in ways that make it much more user-friendly and understandable while ensuring protection of beneficiary information. We recently proposed our overhaul of meaningful use, which is really focused on interoperability and privacy and security, while also lowering burden on clinicians and hospitals. We are requiring that everyone advance to the 2015 edition of Certified EHR Technology in 2019. We know that the vast majority of vendors are ready for this. This new edition is much more interoperability friendly than the older edition. And then a few other things that I won't go into detail, but you can see them here around preventing information blocking, try to also work with commercial payers through Medicare Advantage and exchanges to also be able to also share data, thinking about how we could potentially leverage star ratings around providers sharing data. And we have a request for information out there to seek comment on whether or not we should, for hospitals in particular, but potentially also other types of providers, require that they share data with patients and with other providers, again, in a secure fashion as a condition of participation in Medicare. So that's just a request for information. It's not a proposal. Next slide. Medicare's Blue Button 2.0. Next slide. So Blue Button, some of you may be familiar with this. This is basically HHS-wide effort to, again, allow patients to access their claims data in a way that they can understand, so they can look it up, they can actually download it into a PDF and share it, with their provider. Next slide. So we've launched this in 2010 along in partnership with the VA. The VA released their Blue Button download in August of 2010. We followed the next month with our Blue Button download. But now we need to really advance our technology and take advantage of newer technologies to get these data in the hands of patients in a much more user-friendly format. And so that's the work that we're doing with a number of organizations to develop a standards-based API to be another mechanism by which patients can access their data. Next slide. So pre-2018, we had about 1.5 million CMS users, 20 to 30,000 downloads per month. And basically what you got was a text download, right? So you got, you see it here, a PDF, and I actually did this with my mother, who's a Medicare beneficiary, where we registered on mymedicare.gov, and I was able to download her claims information, and basically you get a file, you get a PDF. And I will tell you, it is not easy to interpret. And I, work for Medicare, and I'm a physician, and I still found it in some ways not always very easy to interpret. And certainly my mom, found it difficult to interpret. So it's definitely time to do the work that we're doing to make this much easier on folks. Next slide. So again, patients, we believe that patients need to have access and control to much more easily share their data with whoever they want, their primary care doctor, their specialist, a family member, whoever they want. So again, doing the work that I've described. Let's go on to the next slide. So I won't get into much of the details here, but the basic design you see here, we are working on development of an open source, so anybody will have access to the code, front-end application that manages both Health IT developer as well as beneficiary access, and the beneficiary access is integrated with mymedicare.gov. Working on an open source reference implementation of the FHIR server, so we're really excited about that, where there would be access to claims data for Medicare beneficiaries through our chronic condition warehouse. Next slide. And that warehouse is really just a repository of all Medicare claims. And so the reason to go the API route, it's much more secure for beneficiaries. And it will make it easier for beneficiaries to access their data. There's a much more granular management of other applications, the ability for APIs to connect with other applications, so it'll be much easier to manage that. And I think really importantly is the presentation of the data, is that it will make it much easier for people to understand. So really focusing on the usability here and doing a lot of testing with beneficiaries on the development of these APIs. Next slide. So I also want to just tell you what we've done recently in our proposed rule around interoperability. This is, again, is the hospital proposed rule. Next slide. So our major proposals were around application of the meaningful measures framework, where we really focused on honing down our portfolio of measures for hospitals, focusing on outcome and safety measures. So we removed 19 measures, and we deduplicated another 21. What that means is we have 5 hospital programs There were some measures actually were in more than one program, and so we basically made sure that each program, what we're proposing is that each program has its own set of measures instead of being duplicative. We also did an overhaul of meaningful use, or promoting interoperability. We have some proposals around price transparency, and we had the RFI that I mentioned before. Next slide. Just quickly about promoting interoperability. So really focused on having all measures in the program be ones that require interoperability in some fashion, and a strong emphasis on sharing of health data with patients. So this really signaled a change in how we view patient data, as well as the safe transmission of health record systems. So we require that, that hospitals undertake a security risk analysis. If they don't do that, then they actually would fail the program. So that's kind of a gateway measure. They have to do that. We also reduced the total number of measures from 11 to about 6. Again, but they're all focused on interoperability, so we think that reduces burden but puts the focus where it needs to be. Our goal is to align this program between hospitals and the quality payment program, understanding that health systems often use a common EMR, and if they have one set of requirements for their clinicians and another for hospitals, that very much increases the burden on that system. Next slide. So we, of course, have the name change. We are proposing a 90-day reporting period in 2019 and 2020, requiring the use of 2015 edition cert because it, again, itself increases the ability for systems to be interoperable, supports that bidirectional data exchange for multiple use cases, which was not true in the current edition. And the scoring methodology for hospitals, I think, is much more rational. It removes the all or none aspect of the program and bases the score on actual performance on the measures, which the previous way it's been done did not do that. Next slide. Oh, I think that's it. Yeah, so this has been, I think, a very, this, I think, as you can tell here, our administration is very, very serious about promoting interoperability, not just the program, but also the concept in numerous different ways. We are continuously looking for additional ways that we can incentivize the sharing of data with patients and the interoperable exchange of data about patients, whether it be an individual patient or populations of patients across providers, again, in a secure manner. And we strongly believe that if we can make significant advances on those capabilities, and make it light touch and easy for clinicians and for patients, that this will strongly support the ability to be successful under value-based payment arrangements, such as the initiatives that or the programs that I showed you earlier. And so I will stop there, and I'm happy to answer any questions.
Thank you so much, Dr. Goodrich. That was a lot of information, but very, very helpful. We really appreciate you sharing that with us. Now we have time for Q&A, and I'd like to remind the audience to please submit your questions in the question panel. So for the first question, Dr. Goodrich, I think because you talked about some of the interagency work that you have been doing, one of the questions that came in was specifically, how are you interacting with ONC on these interoperability efforts to make sure that you're all coordinated and et cetera?
Yeah, no, it's a great question. And I would say ONC is by far our closest partner, certainly in this effort. And we have worked very, very closely with ONC, since its inception, certainly. And I would say that we are very, very aligned with ONC on these efforts. Actually, we couldn't do this without them because we require on them to identify and set the standards for EMRs. They also have a number of new authorities through the 21st Century Cures Act that passed in 2016, very strong bipartisan supported bill. That gave ONC a number of new authorities that were directly centered around interoperability. And they also need us as the regulatory agency to put policies and requirements in place so that so that these EMRs can be interoperable and so that clinicians can take advantage of that interoperability. So we have to be in lockstep with one another. I would just add that in addition to ONC, we've been, I think, increasing our work and our relationship with the VA as well. They're very much a part of the interoperability and the My Healthy Data initiative that really is led out of the White House. So just want to acknowledge them as well because they've been terrific partners.
Thank you, Dr. Goodrich. And there are a couple more questions that have come in for you. The first question is, how innovations will provide value to clinicians to reduce their documentation burden?
So I think there is so much low-hanging fruit with reducing documentation burden. And as you start to investigate why there's so much burden and what the burdens are, it becomes very, very complicated very, very quickly. So there's certainly a lot that we at CMS can do and are actively working on around reducing the burden of documentation. We want to be sure that we are doing that in a way that is fair and that I think protects against some of the reasons we have such documentation burden have to do with really the infrequent incident, overall infrequent incidents of Medicare fraud and wasted abuse and that kind of thing. So we want to be sure that we're still protecting against that, but we are also giving flexibility to clinicians about what it is they need to document for quality improvement purposes, for example. And but that still meets the requirements around billing, for example. So I think you'll see a lot more coming out from CMS around documentation burden. It's not going to happen all in one fell swoop, but we've gotten a lot of really, really great ideas. But I also think that we need the health IT community to innovate on how they can set up, really in the realm of what I would call usability around their systems, to make documentation as seamless and easy as possible. And I think we've seen some examples of that. There are systems out there that have been very, very focused on the usability aspect, and ONC actually is doing a huge amount of work, working with the vendor community as well as clinicians and other providers around usability. So I'm hopeful that as they are doing that work, and as we are doing work around making our requirements around documentation easier and more flexible, that those things can sort of go hand in hand so that we do start to see greater innovations from the health IT community, whether that's an EMR vendor or somebody else, that can really go hand in hand with what we're trying to do to overall reduce burden from the regulatory side as well.
So the next question is kind of a perfect segue to where you just ended. So how can the industry best support or help the CMS or HHS interoperability efforts? What's the best way for industry multi-stakeholders to interact with you in these efforts? So more broadly than data. Mm-hmm.
Yeah, that we would very much welcome that. So we, along with ONC, have been holding a number of listening sessions. I've attended most of them myself, with clinicians in particular, but expanding to others as well, including industry, to hear directly from them, what their ideas are around, burden reduction is certainly one major theme, interoperability as well. And we at CMS have numerous ways in which we interact with the health IT industry. In fact, we interact with them on a very detailed level. I would say certainly at least monthly. We have forums for that, but we also do so on an ad hoc basis. So as we and ONC are doing more of these types of listening sessions, we would very much welcome the industry to participate in that. And, those of you who have worked with me and my colleagues at CMS, as well as my colleagues at ONC, we are always happy to meet with anybody who has good ideas and wants to talk to us about their ideas. So sort of that informal outreach is also very welcome.
Dr. Goodrich, the next question that came in is, can you provide some examples of the measures that require interoperability?
Oh, sure. So these are, we used to call them the meaningful use measures. I guess they are called promoting interoperability measures. So these are not the quality measures. These are really the ones that are part of the promoting interoperability program. So I don't have them up in front of me, so I'm going to do this from memory. And in our proposed rule, and I know there's actually a number of organizations that have also, already put out information that sort of summarizes much about our rule. We have, a number of measures. So one is providing patient access to their health information. Actually, I'm seeing if I can pull this up right now so I can read it to you. So providing patient access. And then there's also supporting electronic referral loops by sending health information, and supporting electronic referral loops by receiving and incorporating health information. So we know that some, for example, for clinicians, some clinicians are more sort of consultants, if you will. And so one of these measures may be more relevant for them, the sending health information potentially, and then the primary care clinician, the receiving and incorporating health information may be more relevant for them. Again, the provider to patient exchange, this is provide patients electronic access to their health. We have, of course, the e-prescribing measure you're probably familiar with, but we have two new measures that we are proposing. One that we have gotten very positive feedback so far on is Query of Prescription Drug Monitoring Program, which basically would require that allows clinicians or hospitals to, what we've been hearing people really want is the ability to integrate their PDMP, their state's PDMP, into their EMR. But there's actually some examples where this is happening, and that the exchange of information or the ability to access information in the PDMP by the clinician or the hospital is really what this particular measure is about. And then there's actually the last measure is around public health and clinical data exchange, where we have one required measure around syndromic surveillance. And then the key here is that, and because we have 2015 edition certified technology, the key here for this measure, to meet this measure, is that bidirectional exchange of information between the provider and the registry. So each of these in some fashion does require information exchange and interoperability.
Thank you so much. And for our last question is for COH Core. So Erin, what are the next steps for Core in our VBP efforts?
Good question. Our next steps are really threefold. The first is we will be continuing this education series. I mean, I think a lot of our research unearthed that there's just a lot of general knowledge building that needs to happen across the industry, particularly from an operational standpoint, on how to create more uniformity and transparency across value-based payment models. The second is that we will be forming an advisory group to look at the opportunity areas and determine which might be most appropriate for Core to take on and address. So that work will be happening over the summer as we do a bit more of a deep dive into the opportunity areas and then launch the group later this year. And then finally, we'll be working with our industry partners and others that are working in this space to really bring the industry together and try to collaborate to create the best outcomes and most uniform approach for the industry.
Thank you, Erin. And unfortunately, we are out of time. Thank you so much, Dr. Goodrich, for taking time out of your day to present for us and answer the audience's questions. We really appreciate it. On the next slide, or on this slide, is information about our webinar series. If you go to our website, you can click on the links and listen to the recordings and take a look at the slides. And I want to thank you, the audience, for joining us as well. If you have any questions about VBP or any of the work that we do, please feel free to email us or check out our website. Thank you very much. Good afternoon.